Good day, everybody. My name is Hugh Hagan. I am a member of the section of hand surgery with the Virginia Tech Carilion Clinic School of Medicine in Roanoke, Virginia. And my topic today is hand surgery and tetraplegia. I have no disclosures relative to this talk. Outline of today's talk: we'll discuss epidemiology, how to pick your patient, and a classification and treatment based upon intact functional level and patient needs, including tendon transfers, joint fusions, and nerve transfers. Take-home messages from our talk today include tetraplegia reconstruction is underutilized. Treatments include tendon transfers, nerve transfers, tenodeses, and fusions. I want you to be familiar with the International Classification for Surgery of the Hand in Tetraplegia. And I want you to remember the priorities for upper extremity reconstruction in patients with cervical spine problems, including wrist extension, pinch, finger and thumb extension, which are capture and release of an object, and finger and thumb flexion, or grasp of an object. These references can be viewed later. These are all good references for general concepts and management of tetraplegia. Over 100,000 American tetraplegics, and their pathology can range from trauma to tumors and infections. And the majority of them would potentially benefit from some upper and limb surgery. This would mean anywhere from 2,000 to 3,000 cases could be performed each year in the United States. But in fact, less than 400 cases are actually done per year, and all years queried in the study by Chung et al., published in the Journal of Hand Surgery in 2005. So when you're considering helping these patients, you have to ask the who, what, when, where, and why. The who: you would need to have a motivated patient with neurologic stability, associated comorbidities under control, including infections, open wounds, and spasticity. Grade M4 at least donor muscles available. Adequate sensation for your reconstruction and controlled pain. And finally, absence of joint contractures, and as I noted above, control of spasticity. What type of management is involved in taking care of people with tetraplegia? Well, number one, you have to be able to work with ancillary providers, including physiatry and occupational therapy. You have to pick procedures that will improve the function in your particular patient. There's a good bit of customization that goes with this. You want to perform procedures as soon as it is possible to do so. And when you're doing tendon transfers, side-to-side transfers as opposed to woven transfers with 5 centimeters of overlap and a running locking suture tend to provide strength of transfer to a degree that early active motion can be begun immediately after surgery. So when do you do it? Prior recommendations advise waiting a year for neurologic stability to be achieved, but in fact, a patient with a complete lesion is not going to show enough change or enough improvement after 6 months to change the treatment options. So the earlier you do it, the better. Sometimes incomplete lesions can be delayed while recovery continues. The sooner your treatment begins, the less trouble you will have with joint contractures, muscle end plate deterioration and permanent denervation, and loss of motivation by the patient, or just loss of the patient into the system. Why are these people to be cared for? The relative infrequency of these injuries in a particular community and the emotional impact of these injuries can, in a variety of ways, delay care. but it is generally better to provide simple, reliable treatments as soon as you can than let the patient get lost in the system. So early, skillfully done procedures by a competent hand surgeon with good postoperative OT and some physiatry support is better than an unpredictable delay for the majority of these patients. And the procedures that are done generally are well within the capability of any fellowship-trained hand surgeon. Tendon transfers, tenodecies, and arthrodecies, with nerve transfers being possible in the hands of some trained hand surgeons. All procedures to consider. Long-term training and reintegration can occur in a more specialized regional spinal cord injury center. But if you can get care started early, that may be preferable for your particular patient. Why are these patients delayed? Well, in spite of the generally good outcomes that come from simple procedures, there are many tetraplegic patients that just aren't referred for upper extremity surgical care. And this is based upon lack of communication networks between physicians, physiatrists, therapists, and hand surgeons. In some cases, it's just not common knowledge that there are procedures that can be done for these people that can change their lives for the better dramatically. So it depends on education of your medical community. If you're willing to take on these patients, then letting the people in the community who might be initial providers of care for these types of patients know what's available. Your goals of treatment really include recovery of hand function. This outweighs recovery of any other ADL, including things like ambulation, bowel and bladder control, and sexual function. Having functional hands makes a tremendous amount of difference in a person being able to become independent or more independent. So the general surgical principles, as stated by Eric Moberg, are try to maintain a supple hand for human contact, strive for simplicity in achieving your surgical goals. And the old quote, I think, which can be attributed to Sterling Bonnell, is when you don't have much, a little bit means a lot. And that's particularly true in the tetraplegic patient. Major functions to restore, as previously stated: wrist extension, pinch, hand opening or capture and release, which means you open your hand to get it around an object, and you can open your hand to release an object, and then hand closing or grasp to enable you to hold on to the object once you picked it up. Wrist extension, pinch, hand opening, and hand closing. Those are the four major functions. And upon those four major functions is driven choices of procedures. Various surgical techniques: tendon transfers, nerve transfers, tenodecies procedures, and fusions, as mentioned before. In order to do a tendon transfer, you fall back on your basic knowledge about tendon transfers. The Medical Research Council grading for motor strength, which goes back to 1943, rates muscle strength in one of 6 categories. There's type 0, no contraction at all. The type 1 is a little flicker of muscle contraction. A type 2 is active movement with gravity eliminated. Type 3 is active movement against gravity. A 4 is active movement against gravity and some resistance. And a 5 is normal. You need to transfer muscles with grade M4 or greater strength to get reliable function out of them. Classifying the level of injury. This is always going to be based upon the lowest functioning cord segment. This will require careful physical examination and perhaps a couple of visits to be sure of your physical findings. Operative planning for any tendon transfer includes making a list of what muscles the patient has functioning at grade 4 or better. Apply the International Classification for Surgery of the Hand and Tetraplegics, grades 0 through 9, which we'll review in a minute. Make a list of what muscles are available for transfer at function grade 4 or better. And make a list of what functions the patient needs. And then you can ask yourself whether tenodesis joint fusion, or nerve transfer could be used in addition to or instead of a tendon transfer. So these are the basics for planning a tendon transfer. Make a list of what muscles work. Make a list of what muscles are available. Make a list of what functions the patient needs, and then consider other options. What about nerve transfers? Nerve transfers are becoming more common. The techniques to enable nerve transfers to be done are becoming more widespread. There are two major studies in patients with tetraplegia that have been performed with the use of nerve transfers that have shown very promising results. Jamie Bertali in 2011 demonstrated that the teres minor branch of the axillary nerve to the triceps would give M4 triceps at 14 months in the majority of patients. And Van Zyl et al. In 2014 demonstrated that same transfer in addition to transfer of the supinator branch of the radial nerve to the posterior osseous nerve, or the so-called spin procedure, gave people M4 elbow extension, thumb and finger flexion, finger extension, and M3 thumb extension at 19 months. Transfer of the brachialis branch of the musculocutaneous nerve to the anterior interosseous nerve has been less effective. So in spinal cord injuries, if you think about your basic neuroanatomy, at the level of the injury, the anterior horn cell, which resides in the spinal cord, is going to be injured. And thus the reflex arc that innervates the muscles in this distribution is destroyed, and the muscles distally are denervated. And this sets the clock for those muscles to about 18 to 24 months. In the absence of reinnervation, these muscles cannot be reinnervated. Above the level of an injury, the anterior horn cells are intact, thus nerves make good donors proximal to the level of injury. And below the level of injury, the anterior horn cells are uninjured and viable with intact reflex arcs and intact innervation to the muscle distally preserved. Thus, distally, these nerves are good recipients for nerve transfer. Nerve transfers can take advantage of this intact motor arc below the level of injury. Excuse me. So how do you evaluate for an appropriate surgical candidate? As stated before, they have to be neurologically stable. They have to be medically stable. They have to have good donor muscles if you're going to do tendon transfers. They have to have controlled pain and protective sensibility if possible. And you have to get rid of joint contractures and control spasticity. You have to basically have maximum flexibility in joints that you're planning to do transfers around, and you have to control the spasticity to avoid later contractures. And finally, last but not least, a patient has to be motivated and have the cognitive capacity for rehabilitation. This is a chart that may be familiar to you from the publication from the Hand Society that shows in general the proximal to distal innervation at each cervical spine level. At the C5 level, this controls elbow flexion, biceps, brachioradialis, and supination, biceps, and supinator. The C6 level, we're talking wrist extension. At the C7 level, we're talking elbow extension, finger and thumb extension, and wrist flexion. At the C8 level, we're talking finger flexion. And at the T1 level, we're talking intrinsic muscle innervation. Looked at another way, if you look at this drawing of the brachial plexus and consider gross motor function at each spinal cord level and what contribution that makes to the peripheral nerves involved, T5 is shoulder abduction and elbow flexion, which is provided by the axillary nerve, and the musculocutaneous nerve. C6 is wrist extension, provided by the radial nerve. C7 is elbow extension, provided by the radial nerve, and finger extension and wrist flexion provided by the radial and the median nerves. C8 finger flexion provided by the median and the ulnar nerves, and the intrinsic muscles provided by the first thoracic. Operative planning, you want to prioritize the functions you're trying to restore. So once again, to beat this home, wrist extension, pinch, capture and release or opening of the hand, grasp, closing of the hand. Now we're going to take a brief look at the International Classification for Surgery of the Hand in Tetraplegia. This classification system describes which muscles function below the elbow. So it's a little bit different than describing somebody as a C5 or a C6 or a C7 tetraplegic. This actually gives you an actual description of what muscles function below the level of the elbow and thus potentially are available for transfer. Individual muscles must have a Medical Research Council grade M4 or greater to be considered functional. So here's the outline of the ICSHT classification. And if you look over on the left, you have groups 0 through 9 and then exceptions. And if you look in the middle column, what these numbers refer to are the number of muscles that are functioning below the elbow. So in a group 0, you have no functional muscle below the level of the elbow for transfer. In a group 1, you have one available muscle that's working, the brachioradialis. In a group 2, two muscles, brachioradialis and ECRL. In a group 3, brachioradialis, ECRL, and ECRB. In a group 4, you can add the pronator teres. In a group 5, the FCR. In a group 6, finger extensors. A 7, thumb extensor. 8, partial digital flexors. And in group 9, you're only lacking intrinsic muscles. All the extrinsics are functioning. And if you look at the far right column, you can see at each level what's retained. So in a group 0, you still have flexion and supination. In a group 1, you neutralize the forearm with the brachioradialis. In other words, if you're supinated and your brachioradialis fires, it'll bring the forearm to neutral. And if you're pronated and the brachioradialis contracts, it'll bring your forearm to neutral. In a group 2, you have some wrist extension. In a group 3, you have strong wrist extension. In a group 4, you have more pronation. In a group 5, you've begun to pick up flexion of the wrist. In a group 6, you can extend the fingers. In a 7, extend the thumb. And an 8, flex the fingers. Excuse me. And you can flex the fingers with more power. In a group 9, you still lack intrinsics. So when we start to consider reconstructive options, you can think of this chart in your head. For instance, in a group 0, with no muscle available below the elbow for transfer, your goal is to improve elbow extension. Improving elbow extension dramatically improves the function of the upper extremity. It increases the space of the world around the patient in which they can do work with their hand. 70% of tetraplegic patients lose elbow extension. Elbow extension also can help with mobility, it can help with transfers, it can help with balance, and it can help with propulsion in a wheelchair. It increases the workspace of the hand by multiple hundreds of percents. So tendon transfers in a group 0 would include the biceps to triceps transfer and the posterior deltoid to the triceps transfer. The biceps to the triceps transfer has more favor currently as it is a straight transfer to the olecranon, where the posterior deltoid to the triceps generally will require reinforcement with a tendon graft and does not retain as much strength or excursion as the biceps does. The biceps to triceps transfer is done in such a way that you preserve the brachialis and supinator function. So you have to have the brachialis functioning for elbow flexion, and you have to have the supinator functioning for forearm supination. You mobilize the biceps by making a pretty generous incision so you can get a straight line of pull, and you transfer it around the ulnar aspect of the arm and underneath the ulnar nerve. And you might say, well, why bother? The ulnar nerve is out. But you may still see recovery, and compression of the ulnar nerve, even if it's non-functional, can lead to secondary systemic effects that might be unanticipated, such as hypertension or pain. Nerve transfers that have been used to improve elbow extension include the previously mentioned axillary nerve branches from the posterior deltoid or teres minor to radial branches to the triceps. And this has been shown, as I mentioned in Bertelli's study, to be an effective way to regain elbow extension. In a group 1, where you have the brachioradialis functioning, what your goals are is to improve wrist extension and wrist pinch. Remember our goals: extending the wrist and improving pinch. Wrist extension can be performed with the brachioradialis, which is available. It can be transferred to the central wrist extensor, the ECRB, to provide wrist extension without radial or ulnar deviation. In addition to this, there are procedures that can improve pinch, which we'll mention in a moment. And these include doing tenodeses and joint stabilizations. Also, in this setting, you can consider the supinator branches of the posterior interosseous nerve or the radial nerve to the posterior interosseous nerve. Remembering that even in the case in which you've lost function of the posterior interosseous nerve distally, if you have intact elbow flexion, you're going to have some intact supination through the supinator, and the branches of the radial nerve that provide power to the supinator muscle can be used as nerve transfers. If your brachioradialis is functioning and you do a tendon transfer that can improve active wrist extension, you can improve function somewhat with the use of an external orthosis, which will pinch the thumb to the adjacent index finger, pulp to side, with active wrist extension. These are somewhat bulky and perhaps unwieldy orthoses, and they're used less frequently than they used to be. What you're trying to do is build the orthosis into the patient's hand. So with Moberg's reconstruction, you do the brachioradialis to the ECRB to give you active wrist extension, and then you do something to the thumb to improve its ability to pinch. What you do is an FPL tenodesis to the volar radius, which, when the wrist is extended, puts tension on the FPL, and then you stabilize the interphalangeal joint of the thumb with a K-wire, as Moberg described it, or more commonly nowadays, by splitting the insertion of the flexor pollicis longus, leaving half of it attached volarly and attaching the other half to the terminal tendon dorsally, which balances the tendency of the distal segment of the thumb to flex when there's tension applied to the flexor pollicis longus. So stabilize the thumb IP joint, tenodese the FPL, and provide active wrist extension. And what this will give you is the ability to pinch the thumb to the side of the index finger. In a group 3, where you now have a second wrist extensor working, and this provides some extension of the wrist, the ECRL becomes available to extend the wrist, and this frees up the brachioradialis. Your goals here are to make pinch stronger and to improve thumb extension. Tendon transfers include brachioradialis now to the flexor pollicis longus instead of the ECRB. This gives you some active flexion of the thumb. You would fuse the carpometacarpal joint of the thumb to place the thumb in palmar abduction. Some people do it simply by fusing the metacarpal to the trapezium, now more commonly done with locking plates, or putting an intercalary graft between the thumb metacarpal and the index metacarpal to hold the thumb palmarly abducted. Thumb interphalangeal stabilization, preferably by split tendon transfer, and EPL tenodesis to the forearm fascia, which, when the wrist is flexed, provides extension of the thumb. Instead of that, you might consider, once again, the supinator branches of the radial nerve to the posterior interosseous nerve, which can provide active thumb as well as finger extension. In a group 3, you have the ECRB functioning. This is a strong and central wrist extensor, and this will now free up an additional tendon. Since the ECRB is working, the ECRL can now be used for transfer. And when we start thinking about the goals of tetraplegic reconstruction, remember, We want wrist extension, which we now have by a functioning ECRB. We want pinch, which we have partially working by our thumb abduction fusion and tenodesis of the FPL. And we have partial tenodesis on finger flexors, which will flex with simple muscle tension when the wrist is extended. We want to provide active finger flexion. How do you know the ECRB is working well enough to free up your ECRL? Well, the wrist will extend without radially deviating with 5-to-5 strength, and the forearm will pronate. If you've got these two things, then for sure you're going to have an intact ECRB and you can move your ECRL. Resisted wrist extension also can produce a groove between the ECRB and ECRL muscle bellies if both are functioning at grade 4 or better, and this is called Bean's sign. So you can see where the blue arrow is pointing to a groove, and it's between the two radial wrist extensors. Now that the ECRB provides strong wrist extension, you can transfer the brachioradialis, just like a group 2, to the flexor pollicis longus. And you can choose to do this by bringing it around the forearm or by bringing it through the interosseous membrane. If it's brought through the interosseous membrane, it will also function as a pronator. And you can transfer the ECRL to the deep flexors of the index, middle, and ring. In general, you would leave the small finger flexor out of this transfer, as it will tend to follow the ring finger passively. And if you tie into the small finger deep flexor with this tendon transfer, because of the decreased excursion of the small finger flexor, you will run out of excursion in your tendon transfer before all of the other fingers can flex. In other words, the small finger would be flexed initially, and the other fingers would be following along, unable to flex fully. And you would stabilize the interphalangeal joint of the thumb once again with a split transfer. And you would consider and probably perform a fusion of the thumb CMC joint. EPL tenodesis to the forearm fascia once again can be considered, but you can also do a spin nerve transfer, which may prevent you from having to do tenodeses of the thumb or finger extensors. Group 4 and Group 5 are very similar. You have a functioning pronator teres and a functioning flexor carpi radialis. And in these groups, the functions that are needed include finger and thumb extension as before, improved finger and thumb flexion, thumb carpometacarpal stability. And tendon transfers to accomplish these goals are all the ones that we're familiar with so far. Brachioradialis to FPL, ECRL to the deep flexors of index through ring, stabilization of the thumb interphalangeal joint, CMC fusion, and tenodesis of the EPL to the forearm fascia. Intrinsic balancing is described by House, includes using free tendon grafts tied distally in to the extensor hood through the lumbrical canal and then tenodesed proximally so that the flexion of the fingers can begin from a position of MP flexion. And this allows improved hand opening to allow for capture and release. Nerve transfer includes the supinator branches of the radial nerve to the posterior interosseous nerve. In group 6 and 7, you have intact finger extensors and intact thumb extensor. So what is your goal here? Your goal is to improve finger and thumb flexion. The EDC and EPL are functional, so no nerve transfer or tenodesis of the extensors are necessary. You only need to improve tendon transfers for thumb and finger flexion. And this would include our familiar ECRL to FDP and active pinch brachioradialis to flexor pollicis longus. So at this level, the reconstruction is starting to become a little bit simpler as more muscles proximally come online. In group 8, where you already have partial digital flexors, your goal is to give stronger flexion to the fingers and thumb. This can be accomplished by suturing the index, middle, and ring finger deep flexors side to side and balance them carefully to establish a more normal cascade. You want to leave the FDP of the 5 out of the transfer And once again, you now transfer the very strong brachioradialis to the flexor pollicis longus. In group 9, you're lacking intrinsics. So how do you reconstruct intrinsics? There are a variety of ways. Remembering what the intrinsics do, flex the MP joints and extend the interphalangeal joints. Thumb intrinsic reconstruction can be as simple as just performing a split FPL transfer and doing an IP joint arthrodesis. You can also reconstruct pinch strength by using the brand transfer of the ECRB through the interosseous membrane, extended with a tendon graft to replace the adductor pollicis. And this can give you acceptable functional position of the thumb plus strong pinch strength. Remember that the intrinsics flex the MP joints and extend the IP joints. A Bouvier maneuver can be performed passively prior to any surgery, and this is done by passively flexing the MP joints and then seeing if the interphalangeal joints will passively extend, suggesting sufficient tension in the extensor mechanism to allow you to simply limit the hyperextension of the MP joint and provide flexion to the MP joint without doing additional tendon grafts to the intrinsic mechanism itself. The Zancoli lasso procedure will improve active MCP flexion. This is done by transferring the slips of the superficial flexor around and through the A1 pulley that holds the metacarpal phalangeal joint in flexion. This turns the flexor digitorum superficialis from a PIP flexor to an MCP flexor, and it limits hyperextension of the MCP joint, putting the hand in a more favorable functional position. What are patient-recorded outcomes of surgical treatment? Well, 70% note satisfaction with surgery. As many patients have shown a positive impact on life. Positive impact on independence with ADLs. Positive response when asked about employment-related factors. Our take-home messages, therefore, are, number one, tetraplegia reconstruction is underutilized. The reason for this is more than likely lack of communication between hand surgeons and other providers. I want you to be familiar with the International Classification for Surgery of the Hand in Tetraplegia, which simplifies classification by simply noting the number of muscles available below the elbow for tendon transfer. I want you to be familiar with the priorities of upper extremity reconstruction, which, for the 5th time, wrist extension, pinch, finger and thumb extension, which is capture and release, and finger and thumb flexion, which is grasp. And remember that surgical options include tendon transfers, tenodeses, arthrodeses, nerve transfers, and in some cases, even functional electrical stimulation. You want to strive for simplicity, and that does it. I hope that this has been a useful exercise for everybody to refamiliarize themselves. I would encourage everybody to look at the references that I provided and to go to the Hand Society's Hand E website and look for YouTube videos describing reconstruction for tetraplegia. These can reinforce some of the concepts that I presented here. Thanks very much.